The first talk is by Dr. Navin C Nanda. Dr. Navin C Nanda is a distinguished professor of medicine and cardiovascular disease, University of Alabama at Birmingham, Alabama, United States. He is hailed as father of echocardiography, father of modern echocardiography by many prestigious organizations and society because of his pioneering work in adult, pediatric, fetal, and peripheral ultrasound. Echocardiography labs and institutions have been named after him in India, and he is founding and the current president of the International Society of Cardiovascular Ultrasound. He has a masterly approach of slowly mastering the depth of the problem. I'll request Dr. Vidyut Jain and Dr. Ashish Malhotra to start the first session.
So good morning, respected Dr. Navin C Nanda and Dr. Manoria. I express from Chairpersons desk my sincere thanks to both of you for organizing such an educative program, and I feel proud to be a small part of it. Echocardiography in last 4 to 5 decades has seen a lot of development under the leadership of Dr. Navin C Nanda, and as Dr. Manoria has already said, he is a father of echocardiography. And I think there is no doubt about it. He has been a part of every invention in echocardiography. He has been a part of even nomenclature committee of echocardiography. And most important, he has educated us. And not only that, he has encouraged us to be the part of every educative purpose for the echocardiography. He comes to our smallest place to educate us and encourage us. Today, the problem of heart failure with trigger ejection fraction we all are facing, and how to manage this patient, right from diagnosis, standard criteria of diagnosis, and the standard management. Dr. Navin C Nanda is going to highlight the advances in the echocardiography, particularly with heart failure with trigger ejection fraction and its various phenotypes. So I welcome Dr. Navin C Nanda to give his oration, and will be definitely very much benefited by his informative talk on this particular subject. Dr. Navin C Nanda, please. Welcome.
This is Navin Nanda from the University of Alabama at Birmingham. It's a great pleasure and honor for me to be speaking at this very important meeting, and I appreciate the invitation from Dr. Prabhash Manoria. Well, when it comes to heart failure with preserved ejection fraction, as we call it HFpEF, in patients with normal ejection fraction, obviously, the American Society of Echocardiography have actually put out 4 criteria that one uses. One is to look at the average mitral E inflow wave divided by the tissue Doppler E prime velocity, average velocity from both walls of greater than 14, septal E prime velocity less than 7 centimeters per second, or lateral E prime velocity less than 10 centimeters per second. We also look at pulmonary hypertension when the tricuspid regurgitation velocity is more than 2.8 meters per second. And one looks at the enlargement of the left atrium, where the left atrial volume index is greater than 34 mil per meter square. Now, if 3 of these criteria are positive, 3 out of the 4 criteria are positive, one can confidently diagnose the patient having HFpEF. On the other hand, if only one criterion is positive, the patient will not have the chance of the patient having HFpEF are very minimal. But then there's a big group in between where half of the criteria are positive, and those are the patients we call indeterminate. So there's a large group of patients where one cannot actually exclude or diagnose the presence of HFpEF. So a study has been done just to try to get this better, process this better by Yogesh Reddy and his colleagues from the Mayo Clinic, and was published in Circulation in 2018. What they did was to take 100 consecutive patients with unexplained dyspnea, and these patients underwent cardiac catheterization. And 61 of these patients were diagnosed to have HFpEF by increased wedge pressure, 15 millimeters or more of mercury at rest, or 25 millimeter or more during exercise at cardiac catheterization. And then when they looked at statistically, and of course they had a control number of patients, which were actually 39, who had non-cardiac dyspnea, when they compared to that, this is the criteria they came out with. Well, out of these, 2 are echocardiographic criteria, One is obviously the same one which we have from the American Society of Echocardiography. That is a Doppler echocardiographic estimated pulmonary artery pressure greater than 35 millimeters of mercury. And also they looked at the Doppler echocardiography, mitral E inflow velocity over E prime, to Doppler velocity average of the two walls greater than 9. And these two criteria were taken. But the other criteria were non-echocardiographic. One was obviously the body mass index greater than 30 kilograms per meter square. So obesity actually was supposed to be very important here. And that had actually 2 points. And also if the patients had actually 2 or more antihypertensive medicines, that was also actually 1 point. And atrial fibrillation was the most important thing of all. If they had paroxysmal or persistent atrial fibrillation, they had actually 3 points. Now, if any of these points added up, which are actually a total of 9, if a patient had 6 of 9 points, then there were more than 90% chances that the patient had heart failure with preserved ejection fraction. And they call this as HFpEF score, going by, of course, metabolic considerations here, the body mass index, obesity, as well as looking at hypertension. Well, an editorial came back shortly after this was published, and they said, well, at least we have a properly validated diagnostic algorithm for heart failure with preserved ejection fraction. So that was hailed as a very important study, which it is actually. But on the other hand, there was also some criticism of the study because they thought major issues remained unaddressed. One was that distinct clinical phenotypes predisposing to heart failure with ejection fraction, such as diabetes mellitus and chronic kidney disease, were not addressed. And of course, plasma biomarker profile was not included in these criteria. So finally, with all the response and everything, they came up with this, that H2FF score more than 6 should be used, more than 5 or 6 should be used for unexplained dyspnea in the absence of other causes of heart failure. And of course, these other causes we can diagnose by other means, that is constrictive pericarditis, like amyloid, high output heart failure, storage disease, or valvular heart disease. So this was, and of course, clinicians should use all clinical information, including history, physical examination, echo, and other imaging techniques to exclude these other causes. Well, then actually, that was in 2018. Then a year later, in 2019, there was a consensus recommendation from the Heart Failure Association of the European Society of Cardiology, and published by Dr. Piske and his colleagues here, and how to diagnose heart failure with preserved ejection fraction. And they came up with these criteria. You looked at 4 domains. One was a functional domain, where they had the echocardiographic criteria of the septal and lateral E wave velocities, as well as the average mitral E to E prime velocity, and also the tricuspid regurgitation velocity. They had their functional criteria. They added one more criterion, which was actually a minor criterion, not a major criterion, and that was the global longitudinal strain less than 16, a global longitudinal strain less than 16%. So that was another criteria they added. They also added echocardiographic morphological criteria, like enlargement of the left ventricle, left atrium, greater than 34 mil per meter squared, same as published in the American Society of Echocardiography. But they also added biomarker criteria for patients with sinus rhythm, as well as patients with atrial fibrillation, where they had NT-proBNP greater than 220 picogram per mil, or BNP greater than 80 picogram per mil. And if there is atrial fibrillation, as you know, atrial fibrillation does result in by itself increase in these biomarkers. So they went for a higher one. Instead of 220, they went the NT-proBNP greater than 660 picogram per mil. The BNP also, instead of 80 in sinus rhythm, they went to 240 picogram per mil. So those are the criteria they used. And what this did was they actually, each of these domains had a maximum of 2 points, and the minor domains had 1 point here. And so if any patient had 5 or more points of these criteria, which actually are mainly echocardiographic criteria, together with the biomarkers added to that, then the patient was diagnosed to have HFpEF. On the other hand, if the patient had one criterion only, then obviously you could exclude HFpEF. But if they're 2 to 4 points, then they recommended diastolic stress test, echocardiography, or maybe even cardiac catheterization. And so what they did was, if you have a breathless patient, first they said you should actually rule out other cardiac or non-cardiac causes. Clinical assessment compatible. If the clinical assessment compatible with HFpEF, then you go for standard diagnostic tests first, including natriuretic peptides, ECG, X-ray, echocardiography. And then if these pre-test results suggestive of HFpEF, then you go to this Heart Failure Association PEF score, which I just mentioned. And if it was high, then they had high HFpEF. If it was low, then you search for other causes of cardiac or non-cardiac dyspnea. But if it was intermediate, you go for diastolic stress test, echocardiography here. And of course, once HFpEF is confirmed, then you can investigate for specific etiology of HFpEF. So here actually, this is the echo stress testing. And if you did that, and you can do that by treadmill exercise echocardiography, more commonly done by bicycle, actually, bicycle echocardiography and using bicycle stress testing. And there again, if the average mitral E P prime ratio was 15 or greater, or the tricuspid regurgitation velocity was 3.4 meters per second, then you actually, all the criteria are fulfilled, and the patient would have heart failure with the preserved ejection fraction. So if you have any indeterminate where the points are between 2 and 4, then you go for this stress echocardiography here, stress echo test. And of course, if worst comes to worst, if you still have a problem, then you go to invasive measurements here. And there again, if your LV and diastolic pressure was 15 or more, or the wedge pressure was, LV and diastolic pressure was 16 or more, if the wedge pressure was 15 or more, then obviously you diagnose patient having HFpEF. And you can also actually do some exercise or leg raising there. And again, if the wedge pressure is high, then you diagnose heart failure with preserved ejection fraction. And of course, if there's if you have done the invasive diagnosis, invasive hemodynamic measurements first, and they are indeterminate to some extent, then you can actually go back to stress echocardiography if you have not done the stress echocardiography in the beginning of these patients. Now, very recently, just about 2 months ago, published in February 2022, the European Association of Cardiovascular Imaging have come up with their own criteria now. These are, if you look at these criteria, they're all echo-based criteria. They have not taken into consideration the biomarkers at all. So what they've done here, and not taken into consideration other phenotypes like obesity or hypertension, what they've done is, they said just look for mitral E to A ratio on the mitral inflow pattern. If that is 2 or more than 2, like here you can show the E wave is much greater than the A wave here, then the patient has elevated filling pressure. On the other hand, if the mitral E to A ratio was 0.8 or less than 0.8, and there's a normal filling pressure, so therefore the patient would not have any HFpEF. But then if you have, if the ratio was in between, greater than 0.8 and less than 2, then you go for these additional criteria, which are similar to what we had in the beginning. That is mitral E to E prime ratio greater than 14, tricuspid regurgitation velocity more than 2.8 meters per second, and enlargement of the left atrium with the volume of more than 34 cc's per meter square. So go for these criteria. If there's 2 or 3 of these criteria positive, then they have HFpEF. If only 2 or 3 negative criteria negative, then they have normal filling pressure. Supposing only 2 criteria are available, and one is positive, 1 is negative, then they suggested one other important echocardiographic parameter, which you have not mentioned earlier, and that is looking at the LA reservoir strain, which is the same thing as peak LA strain. And if that was actually less than 18%, then the patient has elevated filling pressure and HFpEF. If it is greater than or 18%, then the patient does not have HFpEF. So this is the latest criteria that we have from the European Association of Cardiovascular Imaging. Now here, one has to remember, with all these echocardiography, any echocardiography criteria you use, they should not be applied in any of the following conditions. One is no suspicion of heart disease, atrial fibrillation, left bundle branch block, RV pacing, hypertrophic cardiomyopathy, severe mitral valve disease, severe mitral regurgitation, mitral stenosis, or moderate to severe mitral annular calcification, which is very important because old elderly patients who tend to have HFpEF also have mitral annular calcification, and then mitral process repair, as well as high output failure and LV assist devices. So these are the ones you can't declare. Now, when it comes to mitral E to A prime, this is revisited because this was shown long time ago as an important criterion, and that was shown by our group with Dr. Ortiz group from Brazil almost 30 years ago. And what we showed that if the mitral E to F was very high, then actually the survival rate in patients was very low as compared to those where the E to A was normal or where the A was predominantly as compared to the E wave, where the survival was much better. So this actually was had been shown quite a while ago, but has been now revisited. Now let us look at a little bit about left atrial strain. Well, left atrial strain is something new. It's not really normal, echocardiography that we use all the time. I think a lot of people are thinking that should be part of the normal echocardiogram, looking at the left atrial strain. And this left atrial strain, peak left atrial strain or peak reservoir strain, same thing, is actually better than LV strain in diagnosing and predicting outcomes in LV diastolic dysfunction. So this may actually decrease even earlier than some of the other criteria that we use for diagnosing increased left ventricular left-sided filling pressure. One other thing that has come up is to look at actually lung ultrasound. Normally, you get these parallel A lines, artifacts, but when there is water in the lungs, like you have pulmonary edema, then you get these vertical lines, very prominent vertical lines, and these are called the B lines. And of course, they can be due to some lung diseases like ARDS, as well as some other lung diseases. But then when you exclude those lung diseases, and especially when the lung diseases are there, they are usually focal. But if you see them in all the lung zones, and you see these prominent B lines, then you know that there is pulmonary edema. So some people are thinking that can be used as one of the criterion also for diagnosing HFpEF, because we know that in almost 30 or 35% of the patients, even though they have pulmonary edema, but you clinically by auscultation, you don't hear any crackles or rales at the lung basis. So you miss this pulmonary edema, which can be diagnosed using lung ultrasound. And this is just to show from Dr. Vidyut Kano's group, who has actually pioneered this lung ultrasound many years ago. For example, here you see B lines at rest, and this is after stress. When the pulmonary edema gets worse with stress, you can see the number of B lines have increased. And also, if there are a number of B lines and patient pulmonary edema, you can follow them as you treat them, let's say by a diuretic, you will see that these B lines actually will decrease in number. So that becomes something very important. And again, the question arises, should lung ultrasound B lines be used as an additional criterion for diagnosing HFpEF? Well, there's something which may be coming in the future. We're not for sure. What about artificial intelligence? Well, people have looked at artificial intelligence, especially using unsupervised machine learning method, distinguished with the healthy and HFpEF participants actually here. But there are some problems with the artificial intelligence, or especially when you use unsupervised machine learning, you may pick up something quite different, like for example, epicardial fat pad. On the basis of that, you diagnose whether patients have HFpEF or not, and then you really can't be sure whether the artificial intelligence is correct or not. Also, there are epistemological concerns where some of the very well-known philosophers in the last century, like Immanuel Kant and Hegel, they're looking at the limits of human mind intelligence. For example, according to them, real-world structure may be different than what the mind perceives. So there are some problems with artificial intelligence, but I think that is also something which will be very, very important in the future in assessing HFpEF. Thank you very much for your kind attention.
Thank you very much, Dr. Nanda, for highlighting the issue of diastolic dysfunction and clarifying it so well, how to go ahead in our clinical practice and the importance of the echocardiography and clinical parameter ultimately to come to the perfect diagnosis. We are very, this is going to excite a good discussion. One simple question. You have highlighted the importance of NT-proBNP, but the NT-proBNP variable in the different age group, normal values are different. So how do we correlate at that time?
NT-proBNP, as you know, that quite a few is when you have a heart failure with reduced ejection fraction, those biomarkers are high most of the time. But when you have this HFpEF, many patients don't show that. And as you know, as obese patients, and obesity is one of the phenotypes of FF. In those patients, also the biomarkers may not increase. Actually, you may not find increased biomarker levels. So that's why the last we saw from the European Imaging Society guidelines, they've taken off the biomarkers completely. But I think in practice, you really have to look at everything. It's not very easy to make the diagnosis of HFpEF. As you know, jugular venous pressure, not very easy to see in many subjects, obese patients also. And so I think we have to take into consideration everything. But this is what is the latest that we have. These are the new things we have in the diagnosis and assessment of HFpEF.
Dr. Nanda, excellent presentation. I would just like ask a simple question. In many obese patients, the window of echo is very poor, and many times we cannot make out the clear-cut differentiation of all these parameters. So, are you using TE also in such patients, or there's some way to circumvent this problem?
No, I don't think we hardly ever use TE in these patients. I think we go for contrast echocardiogram quite a bit. Contrast echocardiogram helps us quite a bit in looking at the patients with poor windows. And many of the obese patients, if you're very close to the sternum, you many times can get fairly good pictures here. And of course, you can also use lung ultrasound, looking at the B lines to diagnose pulmonary edema.
So with this,
and of course, also one other thing to remember is, in an obese patient, look at the IVC. Because the commonest cause for right heart failure is left heart failure, actually, if you think about it. So if the IVC is enlarged, there is increase in the RA pressure, and maybe there will be increase in the left side philic pressure also in some of these patients. So IVC can be used. So in some of the obese patients, you can go in the subcostal examination and can get mitral E waves and A wave also. Yeah.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.